Welcome to Empowering Plans, a show dedicated to identifying waste and undue expense in the health benefits industry, discovering ways to maximize benefits while minimizing costs, and empowering employers, administrators, and consultants to emphasize, once again, the benefit in benefit plan. Today's episode is brought to you by the FIA Group, empowering plans since 1999. Now here are your hosts, the FIA Group's own CEO, Adam Russo, and Senior Vice President and General Counsel, Ron Peck.
Hello, everybody, and welcome to another episode of Empowering Plans. I am your host, Adam Russo, CEO and co-founder of the FIA Group. With me, as always, is a fan favorite, Ron Peck, our Senior VP and General Counsel. Say hello, Ron.
Hello, Ron.
Last week, Ron tried to screw me up. We were doing our webinar, and instead of saying hello, Ron, he actually said something else, and it freaked me out. I'm like, we're going to have the worst webinar ever. It's going to ruin my weekend. So, Ron, thankfully, you're back on track.
It's like standing for the national anthem, Adam. It sets the tone.
Speaking of standing for the national anthem, I wanted to bring this up for the first time now to see what Ron's reaction was. So, Friday night, I happened to go out to dinner with a few friends and also my partner here at FIA Group, Mike Bronco. And guess who was sitting at the table next to me, Ron?
I can't even begin to guess, Adam.
Bill Belichick.
Stop it. Where were you
Bill
eating?
Belichick was sitting next to me with his girlfriend. They were holding hands the entire time.
Oh, that's nice.
He was drinking Diet Coke.
My guy.
I was trying to take a photo of him, but I didn't. But I do have a photo because one of the people that were with us took a picture of him. He drank Diet Coke the whole night while his girlfriend was drinking white wine. But yeah, no one bothered him. He just sat there. We were in Abington, Massachusetts.
Wonderful.
And I guess he doesn't drink before the game, or at least a couple days before.
No, that's good. And I'm sure he attacked the meal with strategy. He came in from the side of the potatoes and then struck straight at the steak. It was awesome.
I mean, it was pretty cool just to see him not wearing a cut-up hoodie. He actually had a nice dress shirt on and looked pretty presentable. So
nice.
it was pretty cool. So, anyways, folks, we have a couple things we want to bring up today, and this has nothing to do with drinking. It has to do with more than just drinking. It has to do with drugs.
Oh, boy.
And the opioid epidemic that we're seeing across the country. So as you all know, every time we do a webinar or a podcast, we ask people for feedback. Feel free to email Ron and myself at info@FIA Group, or go right to Ron at rpeck or at arusso@FIA Group if you have any ideas or suggestions in regards to topics. But the opioid epidemic, I think, hits home for a lot of people. I know it hits home to me personally, and to a lot of people here at FIA whose friends and families are either struggling with or have passed away due to a drug addiction. So one of the things that we talk about, and a lot of people talk about, is not only opioids, but specialty drugs. Any high-cost drugs, any type of drug patterns that we see, abusive practices, not only from facilities, but abusive practices from actual patients utilizing those drugs. Ron?
Yeah, sure. So the opioid epidemic right now, I think, is the most recent trend or most recent example of this. But Adam, even in the last 10, 20 years, we've seen a number of different instances where the claims data which the TPA is receiving and processing starts to reveal trends that may or may not indicate that something is up. We certainly saw a lot of abuses with the compounding drugs and the compounding centers and the pricing there, overuse of different prescribed drugs where, yeah, there's a prescription and it's technically medically necessary, and so it's covered by the plan. And if the TPA is just doing its job, they're just going to click the button and pay the claim. The question starts to emerge, what obligation or what duty does the TPA have to stop the claim, to mention something to the plan, and maybe take action to try and cut the cost?
Well, let's take a step back for a second. So the last time we did the podcast, I talked about my personal surgery, my elective surgery that I had. And to me, what still sticks out is literally the first thing that the doctor told me after he was done cutting me up was, "Oh, yeah, we have a prescription for you for OxyContin." And I'm sitting there going, I didn't even ask for them.
Right.
I didn't ask about the pain. They never said, hey, you might need the Oxy, but let's first start off with Advil or some ibuprofen or some other type of less powerful drug than, let's say, OxyContin. But it was like, yeah, sure, here's a prescription for 20 pills. Do what you want with them. I just thought that was amazing to me. And more recently, Ron, you might have heard, is that CVS is going to limit the actual number of refills that a person can get. So regardless of what that doctor might be doing, CVS is doing what you just said. Do they have an obligation? No. If anything, CVS is trying to make money. They're trying to be profitable. They should be trying to sell as many drugs as they can because that means people are coming into their stores. So they feel there's some type of social or moral responsibility to say, you know what? We don't care if you have a prescription. We're not going to allow you to buy it from us. You can go somewhere else and get it, but you aren't getting it here.
Sure. That's actually a really great example is the CVS one, Adam, because in your example, had you gone and filled the prescription, would it have been covered? Yeah. Would you have, paid a copay? Maybe. But the plan would have covered the rest. And then let's say hypothetically you have refills and you go in and you get the refills. Again, it's a prescribed drug. It's covered by the plan. Technically, if we were all robots and not reading between the lines, those prescriptions would be filled and you'd get the drugs and we'd keep paying. So then the question starts to become, is it costly? Sure, cost containment is one issue, but then there's also just that, like you said, that moral obligation to maybe step in and say something. I think you see that underpinning a lot of people like to talk about it all the time, fraud. If you see a provider that just generally seems to have unusual billing practices, maybe everything is still payable and it's still legal, but it's raising a flag. At what point do you say something or do something about it?
Well, let's get right into these drugs. So let's start with the TPA. So obviously, I think we both can agree that there is no fiduciary responsibility for a TPA to inform their client plans of specific members that are abusing drugs, because obviously they're getting a prescription. So some doctor out there is prescribing this to them, allowing them to take this in the first place. So that comes to us as people ask, from a HIPAA standpoint, American Disabilities Act standpoint, all these different laws out there. Is there anything out there that's going to require a TPA to basically identify who these people are, or not to allow a TPA to identify who these people are? Let's take it a step back. At the end of the day, is there any fiduciary responsibility for the TPA itself to alert a particular plan about a specific person who might be abusing pills? Ron?
No, not unless they specifically take on that obligation, but I've never seen that, Adam. I've never seen that.
We both agreed that it's just more of a moral compass. It's more of a social feeling that they want to make sure their client plans know, hey, you are aware of these particular people. So here's the first thing I say is every TPA has an obligation, or maybe not an obligation, but what differentiates a TPA from an ASO is that a TPA is sharing that data. Mm-hmm. So what we do with the data that we get from a TPA, our TPA isn't telling us, hey, Fia, look at these claims. They're sending us the data, and then we are looking at the claims. So if a plan has a broker, is it that broker's responsibility to share with them, check out where these high risk factors are for your particular patient and population? I believe so. I think that's where we have to look. It's definitely a plan's obligation to look at their cost trends to see if there's any abuses, because at the end of the day, a plan has to be prudent with plan assets. So you should be looking at what your claim dollars are. So I would say first you want to look at costs, what you're spending money on, because let's face it, OxyContin's not expensive, okay? A drug for MS is 20 times more expensive than Oxy. Sure. So if my job is to reduce the overall cost of care, I'm focusing on high dollar specialty drugs, not Percocets. So I think putting that on the TPA is a little too much.
Agreed.
Putting that on the plan might even be a little too much, because at the end of the day, that plan is supposed to be looking at, we have some high cost trends here. Is there a way for us to mitigate that? Do we also want to add on to the plan's burden? Hey, let's see if there are any people on the plan that are abusing certain drugs, even though they're cheap. They might not be expensive. They're not really abusing the plan's overall cost structure. Do we want to add that, or do we feel that there's a responsibility on the plan to do that, or is it a responsibility of the employer to do that because these people are working for them? Do you want to have a drug addict working for you? That's a big point, Ron.
I think, Adam, you really just nailed it on the head there. When you talk about, is it a cost containment issue? Is it about prudent use of plan assets? Not so much. So it's not an inherent requirement or responsibility under ERISA, which means if you're going to address this issue and consciously filter through the data and look for abuses, you need to make a specific decision to do so. And I think you look at it the same way a lot of plans maybe look at wellness programs, where what's the chance that my staff, somebody is going to have a heart attack at age 40, right, or 36? And yet, I'm going to spend plan assets, get everybody out of their seat, and spend 15 minutes doing jumping jacks. Why? Maybe it's for morale. Maybe it's to show that I value health. Maybe it's to catch the one or two people whose heart attack I potentially prevent. But net, I'm investing time and resources into this, not necessarily to attack a specific cost, but to improve general overall wellness.
Well, you know me, Ron. I'm always thinking from a sales and marketing perspective, right? So how do I look at this? From a TPA perspective, I think there's an opportunity here. A TPA can definitely go out to the marketplace and say, listen, we have an opioid epidemic. One of the things that we're going to do at our organization, at our TPA, is we're going to identify trends. We're going to identify trends that relate to high-cost drugs, specialty pharmacy, and opportunities to replace, not use, mitigate, identify other alternatives. But in addition to that, we're going to look for abuses, not only from providers, but also from patients. Now, that's a huge opportunity. Now, if I am an employee, I'm going to say, wait a second, that's a HIPAA violation. No. We're not going to share with the employer the names of those people. However, the plan sponsor can be given the tools that plan sponsor, who does have a fiduciary duty to be prudent with plan assets, where that plan sponsor can identify, see what the trends are. Are there any people that are abusing certain drugs? They can easily put in the code for that particular prescription and identify, are there abuses? Are there certain providers that are maybe filling prescriptions more often than the average in that particular area? Those are the things, those are areas where I feel the TPA can have a opportunity to do something from a marketing and sales standpoint that the typical ASO and insurance market's not doing. From the plan's perspective, they now have a tool that they didn't have before in order to reduce the overall cost. But this can help combat not only the opioid epidemic, but it could also help reduce the overall cost of drugs, because we all know specialty drugs are rising faster than ever. If there are different alternatives in regards to how you pay for that drug and also what type of usage. I've seen so many slides or so many presentations where people are being prescribed certain drugs where they easily could have been prescribed something else, a generic, that would have cost 1/10 of that particular cost, but they just did whatever their doctor said to do. So I think there are many opportunities here from a TPA's perspective, also from the plan's perspective, and also from the employer's perspective. But I do not believe it's a fiduciary responsibility for the TPA, but I do think it's a huge sales opportunity for them.
Sure, I think it's the difference between cost containment and health improvement. And as with smoking cessation and things like that, where the likelihood of an immediate financial impact is relatively small, at the same time, sick days, yeah, those are costly for the employer. And if someone ends up being diagnosed with lung cancer, that's going to be a costly hit on the plan later on. Same thing here. Somebody's taking time off because they're abusing the medication. At the same time, that's expensive for the employer. What happens if someone overdoses? Is the plan now going to pay to treat that? That may end up being more costly. So I think that vision about health improvement versus immediate cost containment and utilizing it as a way to separate yourself from the pack, Adam, is definitely to the benefit of the TPA.
Well, I think this is great stuff. I know we could do a deeper dive in it, maybe potentially on a webinar, but there are so many different complicated aspects of this. I think it was very important for us to at least bring it up today for this particular podcast. Any other thoughts you want to share, Ron?
No, but thank you to the listeners who send in these comments. More than one person mentioned that this is an issue and they feel that they have an obligation. They see the claims data. What should they be doing with it? I agree. You have the data. That's what separates self-funding from the rest. Do something with the knowledge.
Great information, Ron. So again, on behalf of Ron, Peck, and myself, we thank you so much for tuning in to Empowering Plans. We hope to see you soon. Thank you.
Thank you.